So infection, first is the pyelonephritis. So pyelonephritis is the ascending urinary tract infection that has reached to the pelvis and kidney. It is the inflammation of the kidney, upper urinary tract, that usually results from the bacterial invasion of bladder. So the pyelonephritic kidney become inflamed, hyperemic, and in chronic pyelonephritis there will be multiple scar and atrophy of the cortex. In worsening case, there is a formation of the pyelonephrosis or abscess formation. So type of pyelonephritis depend on the duration of the infection. It could be acute pyelonephritis, chronic pyelonephritis, xanthogranulomatous pyelonephritis, and emphysematous pyelonephritis. So this is picture showing acute and chronic pyelonephritis. In acute pyelonephritis, kidney will be bulky. In ultrasound report, you will see sometime that radiologist he write that bulky kidney, bulky means enlarged kidney, and in the chronic case, the kidney will be shrunken in size. It could be asymmetrical or symmetrical. So acute pyelonephritis is the clinical syndrome of chills, fever, and flank pain that is accompanied by bacteriuria and pyuria. If suppose patient has only bacteriuria, pyuria, but there is no flank pain, then flank pain because kidney located in the flank region. So if there is no flank pain, then we can't tell the acute pyelonephritis. That is the simple UTI. And acute pyelonephritis is the sometimes sudden developing of inflammation of kidney. It is more severe in the patient with immunocompromised patient, especially in the elderly and patient with the HIV positive. So etiology of the acute pyelonephritis, it could be because of vesico-ureteric reflex due to obstruction to kidney stone or ureteric stone, patient on prolonged urinary catheterization, pregnant female, and patient with neurogenic bladder, patient with BPH, and risk factor is the poorly controlled diabetes. So morphology of kidney in case of acute pyelonephritis. So kidney will be enlarged and swollen kidney with bulge on the section. So enlarged or swollen kidney sometimes known as bulky kidney, and on gross examination there will be yellowish red abscess are seen on renal surface. On microscopic examination it involves the interstitium causing destruction of the tubule, and renal blood vessels are resistant to infection. So what are the clinical features? Patient present with the flank pain, fever with chills, rigor. On examination there is a flank tenderness. Patient also complaining burning micturition, increased frequency of micturition. On routine urine examination, so on culture showing there is a colony count of more than 10 to the power 5. So if what are the complications of the acute pyelonephritis if we will not treat this condition? Patient present with papillary necrosis, and it can progress to the pyelonephrosis and renal abscess and a perinephric abscess. So management, this is the infection. First need to control source of the infection. So first need to send urine for culture sensitivity. According to culture sensitivity, we have to start antibiotic. Usually antibiotic given as aminoglycoside, cephalosporin, and sulfamethoxazole. So before starting aminoglycoside, need to check serum creatinine because this is the autoneuronephrotoxic drug. So this is the flow chart. The patient suggestive of the acute pyelonephritis usually by flank pain, fever, and high leukocyte count. In such case, these are signs of sepsis. If all these signs present the patient in sepsis, then need to further evaluate with CT scan and send blood and urine for culture sensitivity. If suppose these symptoms leukocytosis are not there, mild flank pain and patient at 1 to 2 day fever, then we directly first before starting antibiotic need to send urine culture and then wait for 3 to 4 days. If worsening, then need to go for radiology CT scan. If patient improving, then complete the course of the 7 to 10 days of antibiotic. Second is the chronic pyelonephritis. Chronic pyelonephritis, kidney is asymmetrical and shrunken kidney. So it implies kidney infection and chronic tubulointerstitial disease resulting in the repeated attack of inflammation and scarring. So chronic pyelonephritis because of two reasons. One is the chronic obstruction of the kidney. It at various level, at the PUG level and upper ureter, middle ureter, lower ureter, and bladder outlet obstruction. And other is cause is reflex pyelonephritis, usually seen in the children because of vesico-ureteric reflex. So reflex is the multiple episode of recurrent UTI. Because of multiple episode of recurrent UTI, patient develop scar in the kidney and shrunken in the size. So gross anatomy of chronic pyelonephritis kidney is a small and contracted kidney. So contracted kidney are two types: the symmetrical contraction or asymmetrical. Symmetrical contraction in patient with benign nephrosclerosis, usually seen in the patient with poorly controlled hypertension. And in chronic pyelonephritis, kidney is a small shrunken but asymmetrical. So this is your MCQ: symmetrical contraction of kidney or asymmetrical contraction of the kidney. So patient in acute pyelonephritis, patient has history of 3 to 4 day, 1 week, maximum 1 week history. In chronic pyelonephritis, patient has repeated attack of flank pain, fever and tenderness. Usually patient will give within 6 months 2 to 3 times of hospital admission. So patient usually present with repeated attack of fever and lumbar flank tenderness, dysuria, and in chronic pyelonephritis because of kidney size is shrunken, so patient usually develop raised serum creatinine and hypertension. So first the correction of cause is obstruction, remove the stone, or if because of reflex disease, go for anti-reflexive surgery. And such acute pyelonephritis, we have to give only 7 to 10 day antibiotic course. But in case of chronic pyelonephritis, we have to give 3-month course of antibiotic. For first the 2 weeks, we have to give therapeutic. Then next 2.5 months, we have to give prophylactic antibiotic. So usual what is the prophylactic dose of antibiotic? What is the therapeutic dose of antibiotic? So suppose ciprofloxacin, the 5.8 mg BD. So its prophylaxis dose is the usually half of the therapeutic dose. So grossly you can remember like this. Or if and go for functional assessment of kidney, because kidney is small and shrunken kidney. If renal function is the less than 15%, then go for nephrectomy. Another type of the pyelonephritis, xanthogranulomatous pyelonephritis. In xanthogranulomatous pyelonephritis, on gross specimen, kidney show there is a large obstructive pelvic calculus and this is the calculus, dilated pelvic-calyceal system and pyelonephrosis. So it is unusual form of chronic pyelonephritis characterized by the granulomatous abscess formation and severe kidney destruction. Clinical picture that may resemble the renal carcinoma or other inflammatory renal parenchymal disease. So when it resembles the renal cell carcinoma, because patient with renal abscess, patient usually from rural area, they will take IV antibiotic for 1 to 2 weeks and then lead to the antibioma formation, granuloma formation. So such granuloma, the abscess will be thick abscess that look like a solid renal mass. So that's why it resembles the renal cell carcinoma. So granuloma usually a lipid-laden macrophage, and it consists around 20% of the patient biopsy showing pyelonephritis on nephrectomy specimen. So clinical manifestation, sometimes disease is very severe and need ICU admission, and patient usually present in the urosepsis because of the stone obstruction and pyelonephrosis. And because of chronic condition, patient develop anemia of chronic disease and painful renal mass, stone already. Patient has symptom of patient may have the history of recurrent calculuria, and usually because of the pyelonephrosis, that renal parenchyma destruction by the inflammation. So the kidney usually poor functioning kidney. So diagnosis by urine analysis, blood test. So in case of urosepsis, urine culture and sensitivity, and usually for CECT abdomen. So this is the urine analysis I already discussed in first. So other type is the emphysematous pyelonephritis. Emphysematous means gas formation, and pyelonephritis same. When gas in the pelvic-calyceal system, so in such case such patient showing emphysematous pyelonephritis. So it is the acute necrotizing parenchymal and perirenal infection caused by the gas-forming uropathogens. Risk factors are usually seen in diabetic patient, more common in female than male, and the risk factor are obstruction to urinary tract, patient that ureteric stone, and patient usually these patients are diabetic, poorly controlled diabetes. So in diabetic patient there is a papillary necrosis. Papillary necrosis, that slug papilla obstruct the ureter. So in such patient, because of high tissue glucose level provide the substrate for the microorganism such as E. coli, which are able to produce carbon dioxide by the fermentation of the sugar. So on plain X-ray, there will be gas shadow, motile gas shadow on the in the right hypochondrium or left hypochondrium. This is very severe condition, mortality around 50 to 60%. So this is a CT scan saying whole kidney is replaced by the gas forming bacteria, and all destruction of the kidney by the necrotizing destruction of the renal parenchyma. So this is the whole black area is showing gas in the renal fossa. This is the plain X-ray. That's a large arrow showing the perinephric abscess. This large arrow showing the perinephric first one, and the small pocket showing the nephric renal abscess. So renal abscess, also known as carbuncle, also called as carbuncle of kidney, is a collection of the purulent material confined to the renal parenchyma. Most common pathogen are E. coli, Klebsiella, Proteus, and Pseudomonas. Similar to pyelonephritis, patient present with fever, chills, abdominal or flank pain, or occasionally in chronic case, patient present with the weight loss and malaise. So renal abscess could be due to gram-positive bacteria or gram-negative bacteria. If case of gram-negative bacteria, usually from ascending infection from the bladder, could be due to reflux disease or due to obstruction. Or if renal abscess showing gram-positive bacteria, that usually seen because of the either upper respiratory tract infection or either because of skin disease. Or gram-positive infection usually spread to kidney by the hematogenesis spread. So first investigation is the ultrasound showing the hypoechoic lesion in the kidney, and CT is the diagnostic. In CT there is around the abscess hypoenhancing area, there is a peripheral area is the enhancing, so that's showing the ring sign in the CT scan. So this is the ultrasound showing that dense hypoechoic area at upper pole of right kidney. This is the CT scan. If you see that at anterior cortex there is a hypoenhancing area. This one. So in CT, that this is the vertebra, this is the posterior cortex, or that is the liver in the anterior side. This is the anterior cortex, this is the posterior cortex, this is the vertebra. So management depend on size of the renal abscess. If size is small, less than 3 centimeter or even 5 centimeter, but patient is stable, in such case IV antibiotic is appropriate. If more than 5 centimeter, then need to USG guided percutaneous drainage of the abscess, and abscess need to send for culture sensitivity, then further change to antibiotic according to sensitivity report. And sometime I told you that in case of the chronic abscess because abscess become thick and granulomatous, in such case it is resemble like a renal cell carcinoma. In such doubtful case, we have to take biopsy, either CT guided or ultrasound guided. So other thing, common thing you usually seen on the ultrasound report or CT report, that they will write infected hydronephrosis or pyonephrosis. Infected hydronephrosis is the collection of the infected material in the pelvic calyceal system, and pyonephrosis means nephrosis means kidney. The pyonephrosis is destruction of the parenchyma also. So abscess in PCS plus destruction of parenchyma is the pyonephrosis. Only infected hydronephrosis means dilated pelvic-calyceal system plus some bacterial organism. So patient usually present with same thing, fever, chills, flank pain, and on examination there is a renal angle tenderness. Ultrasound showing dilated pelvic-calyceal system with fluid debris level in the collecting system. So CT on infected hydronephrosis or pyonephrosis, CT is non-invasive. But usually what it will show chronic inflammation, that thickening of the renal pelvis, and there is a perinephric fatty standing. Management of pyonephrosis need to drainage of the abscess. If suppose of obstruction, then we have to put PCN tube. If there is no obstruction, then give IV antibiotic. So this is the pyonephrosis showing the thin parenchyma of kidney, dilated pelvicalical system. Last is the perinephric abscess. So perinephric abscess usually is the result of rupture renal abscess. So when this is a sequence. First is the infected hydronephrosis. It will progress to the renal abscess. The renal abscess cross the renal capsule and the rota. Then that is a perinephric abscess. So perinephric abscess also seen usually in diabetic in 30% of the patient, usually due to because of rupture renal cortical abscess, and seen in the 1/3 case it is because of hematogenous spread, and usually seen in the IV drug abusure. And this hematogenous spread usually abscess show gram positive bacteria on culture, or sometimes urinary extravasation. Infected urine extravasation lead to the perinephric abscess formation. It usually seen in the patient is the in a ureteric calculus, obstructive ureteric calculus. In such case, there is a increased pressure in the PCS system, pelvicalical system. This lead to the rupture of the fornices. When fornices will rupture, there is a leakage of the infected urine in the perinephric space. So perinephric abscess, this is your in medicine also, in surgery part also, these are common cause of that perinephric abscess. So thus perinephric abscess should be suspected in patient with the UTI and flank pain with persistent fever after 4 days of antimicrobial therapy. Perinephric abscess are commonly seen concomitantly with the renal abscess. So this CT showing the perinephric abscess in the posterior region. So I told you that this is the vertebra. So this is the posterior aspect of the kidney. That is the anterior aspect of kidney. So this is the kidney part, and this is the perinephric abscess. So management is start IV antibiotic immediately after diagnosis of the perinephric abscess, and this is the abscess need to drainage by percutaneous drainage, and nephrectomy in case of the poorly or non-functioning kidney. Other infection, bacterial infection is genitourinary tuberculosis. So genitourinary tract is the primary target of hematogenous infection and is most common site of extrapulmonary tuberculosis. So most common site of tuberculosis is the lung. Okay, so primary site of TB is the lung. From lung, usually patient will get that renal infection also. So in first bacteria in periglomerular capillary, that bacteria make a granuloma, and this granuloma become latent, inactive form. It can be latent for 10 to 15 years. When patient immunity is compromised, in such case, this granuloma become, these bacteria multiply and form a microabscess formation either in the renal parenchyma. This abscess can progress to perinephric abscess, and if this abscess rupture into pelvicalical system, this patient develop bacteriuria. So in urine culture, unless the abscess this abscess rupture into pelvicalical system, patient urine culture will not grow Mycobacterium tuberculosis. So kidney is the most common site of urinary tuberculosis. So this is the urinary tuberculosis, most common site for urinary, not genitourinary. For most common site of GUTB is the in female epididymis, in male epididymis, female fallopian tube. So patient with urinary tuberculosis usually present with the storage predominant lower urinary tract symptom. Other case, in case of the abscess, patient can abscess and perinephric abscess, patient can develop back pain and flank pain, microscopic or macroscopic hematuria. There is a 20% case show microscopic hematuria, and the rest of the patients show macroscopic hematuria. So how to diagnose this patient, we have to send 24-hour urinary sediment for the acid fast bacilli staining and for culture. So the pathology I already discussed you. So plain radiograph showing plain film finding focus showing the focus calcification. So focus calcification, if suppose calcification is triangular, then usually seen in the papillary necrosis in diabetic patient. If the calcification is the focal and amorphous, amorphous means not a particular shape. So this is seen in the putty kidney, or putty kidney is the end stage disease of renal tuberculosis. So your MCQ also putty kidney is the seen in the renal tuberculosis. So this is the intravenous urogram finding. These are all the finding direct MCQ. That most common earliest finding is the moth-eaten calyces, or sometime fuzzy calyx. Either first, if fuzzy calyx is there, first option will go fuzzy calyx. If first fuzzy calyx is not in option, then first sign earliest finding is the moth-eaten calyces. Other is the irregular calyctasis, phantom calyx, hydronephrosis, and pipe stem ureter, beaded ureter, and ureteric orifice is the Goldfall ureteric orifice. So this is the MCQ. Goldfall ureteric orifice seen in the tuberculosis, and thimble bladder. So these are the direct MCQ. You have to remember this. So now I will show you the each on a radiograph. So this is the infundibular. This is the calyces. This is infundibular. So this is the infundibular stenosis. So isolated infundibular stenosis seen in the tuberculosis. So this is the phantom calyx. The upper one is the phantom calyx. When you will do RGP and severe that infundibular stenosis, the contrast will not go to the calyx. So that appear as the phantom calyx. In second image, there is a multiple narrowing and dilatation of the ureter, and showing beaded appearance of the ureter. This is the small capacity bladder, thimble bladder. That CT scan showing that calcification and the scar on the posterior cortex of the kidney. So treatment you already study in the pharmacology. The first line ATT, first line ATT, which is IV, given by IV route. Can you tell me name? Tell the name of the first line of only first line that given by IV route. Rest are oral antibiotics. Oral. So the isoniazid side effect, can anyone can tell? Common side effect. Orange color is not side effect. So most common side effect is hepatotoxicity. So the common side effect is the hepatotoxicity. All before starting ATT, usually that consultant will see that liver function. So first is the hepatotoxicity. Then isoniazid doing neuropathy, that prevent by vitamin B6. Other is pyrazinamide is the hyperuricemia, pain in the joint. P4 pyrazinamide, P4 pain in the joint. And ethambutol E4 eye toxicity, optic neuritis. And streptomycin is the otoneuronephrotoxicity. So you can remember the side effects of this. So role of nephrectomy. So patient usually recover with ATT, usually for 9 months, but sometimes patient will not recover and progress to that perinephric abscess or that Schwarz abscess. In such case, we have to remove source kidney, infected kidney, because as a source reduction. Or augmentation cystoplasty in case of the thimble bladder to increase the bladder capacity. So how to prevent the urinary tract infection? If pyelonephritis is not treated immediately, permanent kidney damage can occur. So tell the patient to increase fluid intake, consume blueberry or cranberry juice, and increase the intake of the fermented milk products containing probiotic bacteria have all been shown to inhibit the adherence of bacteria to the epithelial cell of the urinary tract and reduce the recurrence of urinary tract infection. So summary is the any infection, early diagnosis and treatment of UTI. If there is a surgical cause, correction of the surgical cause, and glycemic control, especially in the patient with the diabetes, and evaluation with the ultrasound and CT scan, and need to follow up at regular intervals.